And then we come to the last talk of this course, and this is about how to wean my patient from the ventilator. And this talk will be delivered by Professor Massimo Antonelli. He is director of the Department of Anesthesiology and Critical Care at the Milan Hospital, and also professor of intensive care and anesthesiology at the Catholic University of Rome in Italy.
Good morning. My name is Massimo Antonelli, and my task today is to speak about how to wean my COVID patients. These are my conflict of interest. When we speak about the weaning, we have to distinguish between two concepts: liberation from ventilator support and liberation from the endotracheal tube. In both cases, you can have a success and a failure, but the situation is slightly different. Weaning or liberation failure means the inability to tolerate the spontaneous breathing without any form of ventilatory support, whilst the extubation failure, the inability to tolerate removal of the endotracheal tube. So two situations that are indeed very different, and the pathophysiology of them is different as well. The first question that we have to ask ourselves, if the situations are clinically relevant. Indeed, the answer is yes, because they are associated with prolonged mechanical ventilation. A chronic respiratory failure may occur in something like between 1% and 5% of the patients who are mechanically ventilated. There is an increased risk of subsequent nosocomial pneumonia or ventilator-associated pneumonia, with an increased morbidity and mortality. And the other problem is intrinsic to the mechanical ventilation, that when it's discontinued, something like 25% of the patients are not able to sustain the normal respiration with a spontaneous ventilation. And if we refer to the extubation failure, the conditions that are associated with that are the increased duration of mechanical ventilation and, to some extent, increased mortality. If we separate the weaning process in 7 different stages, you have a pre-weaning phase when you evaluate the patients if the prerequisites are present and the possibility of starting the weaning process is there. You have to measure some predictors, and you have to extubate the patient, and eventually, when the situation goes wrong, you have to reintubate them. So it's important to test the patients when we have a difficult weaning several times, and to some extent, and we'll speak a little bit about that, after the extubation, and in case of temporary failure, maybe we can get the help of the non-invasive post-extubation ventilation. Weaning is a progressive process. We have 3 major categories. The simple weaning, when after the first attempt, the patients can be promptly weaned from the mechanical ventilation and eventually extubated. The difficult weaning, when we have a 3 attempt of spontaneous breathing trial, or you can just wean the patient within a week, or prolonged weaning when these 2 conditions are indeed unfortunately fulfilled, which means more than 3 spontaneous breathing trial or more than 7 days. However, just for reassure our audience concerning the weaning process, 70% of the patients are normally weaned. The first question that we have to answer, when a patient is ready for weaning, and we have to put under control a number of different conditions. As first, we have to be sure that there is a resolution or a control of the underlying disease, that inadequate oxygenation is present with a PaO2 above 60 millimeter of mercury while breathing an FeO2 below 0.4 and a relatively low positive and expiratory pressure below 5 centimeters of water. And then we have to control all the extrapulmonary factors. Sepsis, for instance, if you have a septic patient who is still febrile with high fever, or have or patients who have other kind of disorders who are anemic, probably they do not fulfill the prerequisite for continue to be the weaning from mechanical ventilation. Hemodynamic stability with a normal blood pressure and an heart rate which is below 120 are other essential elements for starting the weaning. And then the consciousness is important as well, without any sedation, pain, or anxiety, and the capability of manage the secretions, which are as well important in order to avoid that there will be any derangement of respiration due to copious secretions after the weaning or extubation. However, we can just look at some parameters, some predictors of the outcome. Some of them are very simple, others are more complicated. In general, as you can see, not all of them has the optimal sensitivity and specificity. The most popular is the ratio between the respiratory rate and the tidal volume. As soon as this ratio is below 105, then the patient may be ready to be weaned. Then we have a combination of other parameters: the dynamic compliance, respiratory rate, the oxygenation, the maximum inspiratory pressure index. And this combination is indeed not very easy to be measured, whilst promptly can be tested the amount of the tidal volume that a patient can express. A more sophisticated parameter is the so-called P01, which is the pressure that the patients may generate within the first 100 milliseconds of his breath. In this case, as soon as in the machine, this value, which is normally recorded with a very simple maneuver, is below 6 centimeters of water. In this case, the conditioner follow the prerequisite, must be below this limit. The work of breathing is more difficult to be managed, but probably it's a simpler index is the PI max, which is the maximal inspiratory pressure that the patient can express on a spontaneous breathing during a trial of T-tube or pressure support. Finally, we can also evaluate through the ratio between pressure and volume the static compliance. As soon as these different parameters are fulfilled and satisfied, we can be relatively sure that the patient will be successfully weaned. But once again, the preconditions are essential. When we declare a patient successfully weaned, independently to the kind of weaning we are adopting, the pressure support ventilation having a level of pressure support between 5 and 10, with a 0 PEEP for let's say 30 and 120 minutes, or when we use the T-tube, which means the disconnection from the ventilator on a flow by for 30 to 100 or 120 minutes without any PEEP, entirely on spontaneous breathing. If under one of these two conditions, the patients maintain a respiratory rate below 30 or 35, a normal pH, an adequate oxygenation, hemodynamic stability, remain on satisfactory consciousness, and does have an effective cuff. In these, under these circumstances, the patients can be weaned. If the trial is unsuccessful, we have to reassess and undergo the patient to a daily screening. There are some questions that are open, and I try to answer these questions, just showing you some studies. Is there a preferable spontaneous breathing trial? Shall the patient rest after the spontaneous breathing trial? High-flow nasal cannula for all patients after extubation can be used. Is the non-invasive ventilation after extubation always dangerous or useful in hypoxemic patients? First question, are all spontaneous breathing trials the same? We have to decide if it is true or false. Well, if you look at one of the classical meta-analyses collecting various studies and where the spontaneous breathing modalities were compared in various conditions and just having a different duration of the spontaneous breathing trial and looking at various outcomes, some of them are illustrated by my previous slide where I showed you the indicator. The conclusion is that in general, by using the pressure support ventilation in these studies, including this meta-analysis, there is a balance in favor of the using of this technique respect to the TPs. And also this is true for some subgroup of patients or subgroup of indicators where once again you can see that the pressure support ventilation may be more effective in weaning your patients. However, there are also conditions when you look at other kind of situation, the extubations in total, the successful extubation is balanced in the two different situations. Going on, we can always, comparing these two different conditions, having a lower rate of successful extubation using one or the other. And a trial has been accomplished in a randomized fashion, just including a number of patients and receiving two different forms, or spontaneous breathing or spontaneous breathing with TPs or pressure support. And under these conditions, the comparison of these two methodologies for weaning the patients was translated into a higher success for those patients who were extubated after the first spontaneous breathing trial when the investigators used the pressure support. More frequently than it happened when the 2-hour TPs trial methodology has been used. But the intubation rate, however, which means a failure of the weaning process after the extubation, was absolutely similar. And the final successful extubation was indeed higher in the patient who indeed received the spontaneous breathing trial. This is the graphical representation of the successful extubation rate in the Kaplan-Meier curve. So we have to answer these questions and we compare. We can say that these are not the same, and probably looking at this data in this randomized trial, the possibility of having a better weaning by using the pressure support seems to be the answer. The other question can be starting from the consideration that the effort induced by the spontaneous breathing trial may be excessive in some patients, a period of rest after the spontaneous breathing trial and before the extubation may be advisable and can reduce the respiratory failure after the extubation and consequently the reintubation. Well, looking at the trial that investigated this issue, reconnected the patient to the ventilator when they allowed them to rest before the final extubation. In a random way, they analyzed 243 patients in a group versus 227 patients in the other. And the successful intubation was indeed absolutely similar, with a significant difference in terms of reintubation. So those patients that had indeed a rest had a lower rate of reintubation. However, what was the major difference was the level of consciousness that between the two groups just focused on a level of consciousness that was better for those patients in the rest group. The other interesting point coming from the study that another determinant, as I alluded before, to the unsuccessful weaning may be the presence of copious secretions that in this case were more represented in the control group in a trend close to the significance but not entirely significant, as well as the presence or not of an underlying medical disease. Then, for answering this question, we can say that it's probably true that if we give a rest when you have some trial of spontaneous breathing, this may be better for the patients. But indeed, the counterbalance is also that we are probably not induced to change our clinical practice if, after all, we have these positive results coming only from one study, and there are some pathophysiological rationales that are not very clear. So let me leave you with a dubious and not change the normal clinical practice. Probably we need to go deeper inside this aspect. High flow nasal cannula for all patients, true or false? Well, coming from our study, from our group, we had a study focused on the high flow after the extubation. And what we noticed that by using the high flow respect to those patients who were randomized to the conventional oxygen therapy after the extubation and developing a slight respiratory failure, the respiratory rate, the oxygen saturation were indeed better for those patients who received high flow oxygen therapy. And looking also to the number of patients who needed the ventilatory support after, during the 48 hours after the study period and then after the intubation, those who were indeed in the control group respect to the high flow nasal cannula had more frequently the need of receiving ventilatory support. If you look at the patient as in the same circumstances, but in low-risk patients, once again a randomized trial, almost with the same number to those that I showed in the previous study, we can see that there is a very different reintubation rate as soon as you compare the two techniques after the extubation in these low-risk patients. And those who were receiving high-flow therapy indeed were less frequently reintubated after the extubation. The other important study, it's a study coming from the French multi-center randomized control trial, where another two groups of patients were allocated to receive the usual care or the high flow oxygen therapy as soon as they have received in a surgical situation abdominal surgery or thoracic surgery. And comparing the two techniques, there is in this case no difference between the two, the usual care or the use of high flow oxygen cannula. And specifically for those patients who were receiving the cardiothoracic surgery, once again, you have a similar result with overlapping conditions. And specifically in a group of patients who, after lung resection, had received the Venturi mask or the high flow oxygen cannula, the final difference was negligible between these two techniques. So it's important, the final message of remembering that maybe the high flow oxygen cannula may be a good way to supplement with the oxygen patients who had the occurrence of a respiratory failure after extubation, but it depends on the different categories of patients. So nasal cannula for all, this is false, and so we need to select specific categories. Probably when we use this technique in patients who are receiving the high flow oxygen therapy because of they developed after extubation an oxygen failure in having the COVID-19, maybe can be advisable to use this technique. What about the non-invasive ventilation? Can be dangerous in patients who are hypoxemic? Indeed, this is a balance between the early extubation by applying this technique or the possibility of delaying the reintubation that may be necessary and then detrimental. And looking at the data that are relatively old and published years ago by Andres Esteban, the final results is not in favor of the non-invasive ventilation. But there are some considerations to make looking at that study, that probably the patients were not very well selected. And under these circumstances, the selection created a selection bias, pushing in favor of a detrimental effect for the delay of needing reintubation for these patients. However, I think that we always to keep in mind the various criteria for the enrolling patients and studying them after the extubation. And to some extent, there are indications that also patients who are hypercardic may be included into the evaluation of the use of non-invasive ventilation after the extubation or after the weaning process, respect to those patients who were needed, who were receiving the normal, usual therapy. And once again, we have the same identical results, that those patients who received the non-invasive ventilation, were looking at the various parameters and predictors, had indeed a lower, a higher rate of reintubation when these predictive values were not satisfied. Early extubation, once again, another study, and this one concluded that there was no real difference between control treatment and those receiving non-invasive ventilation in comparison to the standard treatment. Shall we then extubate on NIF? Probably in highly selected patients, especially hypoxemic patients. The early extubation can reduce the days that these patients can spend on invasive mechanical ventilation, reducing the rate of VAP and tracheobronchitis. However, once again, if we refer to other categories of patients, such as the surgical ones, the benefit seems to be lost. And in this case, we may say that what is prevalent, the advantages coming from the early extubation. In general, is always a balance between respiratory muscle load and neuromuscular capacities. And but there are also other situations that have a weight for determining the failure or not. For instance, speaking about the cardiac failure that it can be often under-recognized. The number of possibilities that interfere with a successful weaning are enlisted in this cartoon, and there are they go from the increased elastic workload up to the inadequate reversal of narcotics. So a number of different conditions. But you have to always remember also that there are other conditions that should be mechanical, but fundamental for not allowing a successful weaning. And for example, when you have still an inflammatory process, when you have, like in the second X-ray, the presence of a selective intubation and then an atelectasis of the one of the two lungs, when there is an obstruction of the endotracheal tube, as well as when we have an upper way obstruction related to the vocal cord inflammation. So we have to apply a sort of mechanical treatment. For example, the correction of the airway obstruction, or the stenosis in case of you may have a defect of the cardiac efficiency or a valvular defect. Finally, the last message is to say that, as you have seen, you have a general principle, you have various conditions, and you have to keep in mind your patient. The final message is that the precision medicine applied to every single patient, because one size doesn't fit for all, is the fundamental polar star to look at for in the interest of your patients. Thank you.
Allow me to briefly summarize what you just told us and ask you some very practical questions along the way. So you told us that it's very relevant to wean as fast as possible. So in fact, to assess this every day, and that the patient is ready for weaning then when there is resolution of the disease symptoms with improvement of hypoxemia and no extrapulmonary factors and awake and strong enough. So in COVID, you may also have experienced that there is seems to be a biphasic course of disease in some patients that go well and then they go bad again. What would be your idea about this? To wait for this biphasic approach, or to just start weaning whenever you think the problem is resolving?
I guess that it depends on the severity of your patients, in the sense that if the underlying process is resolving and the chest X-ray or the CT scan is dramatically improving, then we may make the attempt, provided the fact that the other criteria are fulfilled. But if you have still something that, despite the improvement of the gas exchanges that are promising for just predicting the possibility of a successful weaning, you see that the underlying process is not completely resolved. Or, for instance, the inflammatory indicators that can be the dye dimmers, the dosage of IL-6, the PCR, or whatever, are still relatively high, then you may predict that there will be a second heat, and the real resolution of the process is not there yet and need to be prudent. However, in general, for patients who are very severe, are receiving invasive mechanical ventilation, they in the end stay a bit longer on mechanical ventilation respect to other patients.
Okay. So then you talked about the use of the spontaneous breathing trials, and you showed us data that suggests that the use of pressure support ventilation is maybe better than the TPs. Could you explain to our colleagues in a practical way how you should perform a spontaneous breathing trial in the pressure support mode?
Of course. What you can do if your patient is intubated, you have to set up your mechanical ventilator in order to compensate the extra work of breathing that can relate to the resistances connected to the presence of the intratracheal tube. And in order to do that, it's sufficient to set up something like 8 centimeters of water, or even slightly less of pressure support. So the patients compensate this extra work, and keeping the patient at ZEEP, which means without any positive end expiratory pressure. And if during this period, that can be from half an hour, in the best cases, up to 120 minutes, the patient maintains a good stability, hemodynamically speaking, and looking also to the other respiratory parameters, respiratory rate, for example, or heart rate, then the patient has surpassed the exam, let's say, it can be successfully weaned. So the technique to the practical setup is very, very simple.
Thank you. So, and then after extubation, if it fails, you talked about high flow nasal cannula that can decrease reintubation, although not in all trials, for example, not post-surgery patients. So in a previous session, we discussed high flow nasal cannula as appropriate for hypoxemic failure, whereas NIV may be more appropriate for hypercapnic failure.
That's
so
correct.
Do you agree with that?
Substantially, yes. I'm sorry, please.
No, so my question would be, if we again focus on COVID patients, you can of course have a COVID ARDS, but it is also possible that you have exacerbation of COPD due to COVID. Could you elaborate a little bit on based on physiology, of course, because we don't have data, what is your idea about the ideal post-extubation follow-up oxygen therapy?
This is a very good question. And as you said, not having data, we have to base our decisions and our recommendation on physiology. And under this, the umbrella of this reasoning, we can say that, for instance, all those patients who are COPD and whose PaCO2 as a trend increased trend related to this underlying disease, by using the pressure support and then ensuring a better ventilation after the weaning process may be helpful for them, and reducing the amount of PaCO2, restoring the not so-called normal level that they have in the under normal or so-called normal conditions. However, in general, I would say that also for hypoxemic patients, despite the usefulness in COVID patients of the high flow oxygen therapy, also the use of non-invasive ventilation may be beneficial. Once again, as soon as you clinically have the sensation, the feeling that the patient is increasing his work of breathing, by using the pressure support, you may give a relief to respiratory muscles, reducing the workload of the respiratory muscles, and probably giving some beneficial to the patient. So as I concluded, I guess that we have to individualize to the COVID patients, depending upon which is the underlying disease that was present before getting the COVID.
Okay, thank you very much for your clear explanations, Professor Antonelli. Goodbye.
Thank you very much for your question. Bye.